So this is basically a story of a woman and how she had to go through multiple encounters before she finally got the diagnosis. So it's a 78-year-old female, which she was perfectly fit and well, no past medical history. She lives alone. She's independently mobile. And on September 2012, she presented to the orthopedic outpatients at the clinic here in Manchester to review post bilateral hip replacements. And no concerns were identified at this time. In July 2016, she had a low-dose CT thorax as a part of a lung health check pilot scheme. There were several subpleural 5 millimeter pulmonary nodules were identified, and there were no concerning features on of lung cancer. So in July 2017, she had a follow-up CT, which showed several stable tiny micronodules. It showed a 3 millimeter nodule apical segment in the left lower lobe, mild bilateral axillary lymphadenopathy, which had increased since the previous study, and no mediastinal or hilar lymphadenopathy. She then goes on to attend the ED because she has several skin lesions around her arms, which was believed to be infected eczema, and she was treated with flucloxacillin, and then she was just sent home from the ED without any admission to the hospital. In August of 2017, she gets a letter from the Lung Health Check Pilot Scheme. They say that there are no concerns regarding lung cancer, but his CT has noted axillary lymphadenopathy, and she is referred to the GP to review the lymphadenopathy if any further investigations are needed. In September of 2017, she presents to the outpatient breast clinic and she is reviewed to the axillary lymphadenopathy. An ultrasound and mammogram are done, which are nil acute. They take biopsies of the lymph nodes, which show harmless changes, and she is discharged from the breast services. Now, 2 years later, in March of 2019, she goes to audiology outpatients and she is assessed and arranged for some hearing aids to be fitted. In October of 2019, she is referred because she is having weight loss, dysphagia, and reduced appetite. She goes to the gastroenterology outpatients and she's planned for a CT scan. She has a CT thorax, abdomen, and pelvis, which shows that there continues to be enlarged axillary lymph nodes. These may need to be further investigated with a dedicated ultrasound. Since the previous CT study, there is now a 6 millimeter nodule in the left lobe. If you remember, it was 3 millimeters previously. This will need to be followed up with a repeat CT scan in 6 to 12 months' time in the first instance. In November of 2019, she goes back to the gastroenterology clinic. They explain the CT scan results to her and tell her that it has shown lymphadenopathy and a lung nodule. And she is referred now to the respiratory and back to the breast services for an ultrasound of the lymph nodes. The previous CT scan in 2017 results were also noted at this time. In the same year, she goes to the respiratory clinic and they note multiple lymphadenopathy and multiple lung nodules from CT, and they have planned again for a 3-month interval CT scan. In December of 2019, she has axillary ultrasound and biopsy. She also gets a core biopsy done, and she received a letter from the gastroenterology department stating that ultrasound and biopsy of lymph nodes showed increased reactive changes only. In March of 2020, she is having ongoing weight loss, dysphagia, and she's noted the ongoing lymphadenopathy by the gastroenterology team. She's planned now for a repeat CT tap, an endoscopy, and she's referred to dietitians. She goes on to have the colonoscopy. It doesn't show any colonic lesions or any significant polyps. There are some inguinal nodes, splenomegaly, which is slightly bigger than before, small collapsed sliding hiatus hernia, and they advise an endoscopy. In March of 2020, she does have a CT thorax as per the respiratory team, which showed a progressive mild axillary lymphadenopathy, previously biopsied and reactive, stable small pulmonary nodules. She goes on to have the review with the gastroenterology team, and they say that the OGD results showed evidence of esophageal candidiasis, and the CT tab shows ongoing lymphadenopathy and splenomegaly. In April of 2020, she has a radiology MDT discussion, which includes the gastroenterologists, and there's a decision to have an ultrasound axilla, a true cut biopsy, and a referral to hematology. The core biopsy results show lymphocytes only, and she's referred to dietitians because of her loss of appetite, and they have made plans to increase her oral intake. In April of 2020, she gets a hematology phone review, and the results have noted, and at this time when she gives history along with the dysphagia and the weight loss, she's also saying that she's having some night sweats now. They plan a face-to-face review, and they plan for a lymph node excision biopsy as well. In 2020 of April, she gets a gastro letter with full histology results, again documented no concerning features from the biopsy, and they was queried if this was possibly more of a systemic cause. She's planned to await a review from hematology. The next following month, she goes to the respiratory medicine clinic. They have her repeat interval CT scan, which show that the nodules appear benign, and she's again discharged from the respiratory team. She goes back to the hematology team, but she didn't show up to the appointment, so the appointment is DNA'd. In July, she has the dietitian review appointment, and they advise her some further supplements and just some ways to increase her caloric intake. In August of 2020, she goes to the hematology outpatients at the local clinic at Wythenshawe. She is reviewed for weight loss and lymphadenopathy, and they've planned for a repeat CT scan on a two weight week pathway and bloods, including serum free light chain and LDH. She has the CT tap, which shows mucosal polyp in the right maxilla sinus, small 1.3 into 1 centimeter cystic area in the left parotid, slightly prominent submandibular and upper cervical nodes, no supraclavicular lymphadenopathy, ultrasound is advised, stable enlarged bilateral axillary and inguinal nodes, no thoracic lymphadenopathy, stable small volume left para-aortic nodes, and are not size significant, small subcutaneous muscular nodes in the left anterior presternal region, and stable splenomegaly. So now she's also having submandibular and upper cervical nodes which are prominent. And obviously the axillary and the inguinal nodes have also enlarged. In September of 2020, she receives the hematology letter. They note the CT results, the cervical, submandibular, and the axillary lymphadenopathy. And at this time, the patient is also reporting a right breast lump, and they plan for possible lymph node excision biopsy, and they refer her back to the breast services. The following month, she is seen by the breast services in Manchester. They do an ultrasound and a mammogram. Again, no concerning features are seen. The lump noted to be on ultrasound is a dense glandular tissue. Excisional biopsy is done, and now she's awaiting the biopsy results. In October of 2020, she gets her ultrasound of the salivary glands done, the parotid glands, and it is concluded that she has multiple pathological appearing cervical lymph nodes. Left parotid lesions may represent multiple Warthin's tumors, and fine needle aspiration cytology is sent. In November of 2020, hematology planned to review in clinic post FNAC results, and it shows only reactive lymph nodes on biopsy. She gets a letter again from the breast clinic, which noted the pathology results and also noted that the pathologist has suggested a toxoplasmosis screen, and the patient had reported recurrent breast infections around her nipple at this time. She is discharged from the breast services, and she receives hematology. She goes to the hematology clinic at Manchester. The patient is reassured regarding the biopsy result. The low vitamin D levels are noted, and she is noted advice for the toxoplasmosis screen. She is referred to GP for vitamin D replacement, and the toxoplasmosis screen is sent at the same time. In 2021, now she has an ultrasound neck, and there have been no significant change in the bilateral cervical lymphadenopathy. In January of 2021, she receives a telephone appointment from the gastroenterology. They noted that the patient was concerned about increase in size of lymph nodes behind her ears and ongoing dysphagia. She is referred for barium swallow and manometry. In the meantime, she receives a hematology letter to infectious diseases, which is noted the toxoplasma screen has come back IgG positive and IgM negative, and she is then referred for an infectious diseases review. Finally, in February of 2021, she is reviewed by the infectious diseases team. They do a thorough history and review. They send parasite for cytology, for CT head, an HIV screen, and a full infective screen. And obviously, when the screen comes back, her CD4 count is only 8 and her viral load is 346,000. And these results were received by the infectious diseases team. She also goes on to have the MRI head because the infectious diseases team has done that as part of the HIV screen. The MRI head shows no intracranial mass or hemorrhage syndrome, no intracerebral edema to suggest ongoing encephalitis, no suspicious intra or extra axial post contrast enhancement. In February of 2021, the infectious diseases finally review her face to face and they explain the results of HIV to her. When the results of her were explained, obviously a duty of candor was done because over a period of 5 years, she had been in and out of hospitals and no one had thought that she had HIV. When we discussed the feelings around the late diagnosis for incident feedback, she said that she found it really helpful to have an answer. She was shocked by that the results had been forgotten about the potential risk. The colonoscopy was the most painful experience of her life, worse than childbirth, and she really wished that she would not have had to go through this investigation. She was understandably frustrated at all the results and investigations that had to have been done. We obviously reflected on this as we get a lot of similar incidents like this in this country as well. A major incident was raised and feedback was provided to the GP, the respiratory team, the breast team, the gastro team, and hematology. Notably, there are multiple HIV indicator conditions present in this case, namely weight loss of unknown cause, the lymphadenopathy of unknown cause, and the diagnosis of esophageal candidiasis, which should have prompted an early HIV testing. Overall, from 2017 to 2021, this patient was reviewed over 20 times by 4 different specialities with the same presentation of unexpected weight loss and lymphadenopathy without having an HIV test being sent. On review by the infectious diseases team in February 2021, it is noted that this patient had traveled to Gambia annually, which has been an HIV prevalence of 1.8% in 2020. It doesn't appear that it had been picked up during her previous consultations when she was investigated by the above specialities, and it may have prompted earlier testing. Basically, no one had just simply taken a travel history, and if they had, they probably would have picked it. So there are some biases when we dig deep into the case. Obviously, there are some biases, which is one of the reasons this wasn't picked up. Obviously, she's a Caucasian female, and she's old age. She was 71 when she presented. She is heterosexual, so she doesn't fall in the characteristic demographic of patient who presented with HIV. The UK has a greatly increasing number of HIV, with Greater Manchester being the area with the largest number of HIV cases, with the 16.4 rate of cases diagnosed in 2022. These are the results from 2022. So what has happened in UK, in most part of the UK, particularly in Greater Manchester, is now we have ED opt-out testing program. This means that anyone aged 16 years and over attending a participating ED who is having a blood test for any other reason is tested for HIV and hepatitis C unless they opt out. So this was introduced in December 2021. And since December 2021, over 2 million HIV and hepatitis C tests have been conducted at the Manchester Foundation Trust through the ED opt-out testing. More than 80 people have been newly diagnosed with HIV, and more than 230 people have been newly diagnosed with hepatitis C. An additional 44 people living with HIV and 57 people living with hepatitis C have been identified who had a previous diagnosis but were not linked to care. So this is the ED opt-out testing system which has been introduced in Greater Manchester. So every person gets the test until they actively opt out. However, patients still do get missed because obviously not everyone presents to the ED. There are STEC referrals, which is the same day emergency treatment referrals. The direct GP referrals get missed, and the specialist clinics, for example, in this case, the hematology clinic and the respiratory clinic, they were missed because we do not have mandatory testing for clinics. This is something that we're trying to introduce in the UK to get basically every person who comes to any point of care, whether that's the GP or the specialist clinics, should have HIV tests sent when they have all of their bloods, unless they do opt out. The important take-home message is always think about HIV when we have these presentations, and not to have these biases, especially in older patients, because now we are beginning to get a population of older patients with HIV, and I think that's the population that gets missed the most. Thank you so much.